Hi, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I would like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website on our impact seminar page. I will post the link in the chat, along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, we will not have an impact seminar next month in July. Instead, the next seminar will be on August 4th with Dr. Lisa Rotenstein. And with that, I will turn it over to Dr. Paige Dong to introduce our speaker.
Hi, everyone. It's my pleasure to welcome you and to introduce today's seminar speaker, Dr. Zach Landis-Lewis. Dr. Landis-Lewis is an associate professor in the Department of Learning Health Sciences at the University of Michigan Medical School. As a researcher and educator in biomedical informatics, implementation science, and human-centered design, he studies how to support healthcare professional learning and clinical quality improvement through coaching and appreciation feedback via large-scale digital interventions. He holds a PhD in biomedical informatics and a master's of library and information science from the University of Pittsburgh. Today, his talk is titled Scaffold, Scalable Coaching and Appreciation Feedback for Optimal Learning and Decision Making. With that, please join me in welcoming Dr. Landis-Lewis.
Thank you, Paige. It is wonderful to be here. I appreciate the opportunity to share our work and to be here as part of the Center for Learning Health System Sciences. I'll be presenting today about Scaffold, which is an open source software application we've been developing and studying to generate precision feedback. So I'm going to share some preliminary results from a cluster randomized controlled trial and first kind of walk through what Scaffold is and how it works. I want to start by acknowledging the many people who've helped to make this project possible, including several instrumental team members, colleagues at the University of Michigan, and our funders from the National Library of Medicine. I want to start by recognizing that healthcare professionals are learning all the time in lots of different ways. And increasingly, we have clinical data that can support learning and can be used to generate feedback, which is essential for improvement and sustaining performance. But the tools we have generally aren't good at keeping up. They're not good at recognizing differences in context, people, and as things change over time. So the evidence we're building our work on is from the field of implementation science and from this implementation strategy called audit and feedback, where performance summaries are being delivered to healthcare professionals, often regularly in reporting systems and dashboards. And a recent systematic review just shows a wealth of evidence demonstrating that feedback is moderately effective. And that we have a kind of now nearly 300 trials, so we don't expect this evidence to change anytime soon. And our take on this is that we recognize that feedback is effective, and that it also seems to lack value because there tends to be low engagement with these reports and dashboards. So the challenges we're focused on is really from the perspective of healthcare professionals receiving feedback. What is the value of feedback? How do people engage with feedback? And how are their information and needs and preferences that might differ or change within and across providers and teams? We've built our ideas kind of on this particular definition of feedback that can be used to mean, that word can mean many things. We often mean, the delivery of performance information, hopefully that's actionable, but feedback can also mean influence, direct influence, like balancing or reinforcing feedback. And we've taken this definition and are building on this definition from a book about how to receive feedback well, and think about it from the perspective of the recipient as any information at all that you receive about yourself. So from this perspective, we can recognize there are three different types of feedback. And we can start with thinking about evaluation feedback as kind of what we're doing normally when we're measuring performance, sending that information to people or making it available as scores, percentages, et cetera. And often this includes comparators where, there are performance levels that people are compared with in goals or benchmarks. And then those are visualized with trends so that we can see how performance is changing. And so we can think of this as standard audit and feedback. This is mostly what we're all doing most of the time. And that kind of regular delivery of performance information is different from coaching feedback, where we're estimating, does this person have a learning opportunity? How have they improved? And how can we motivate them to keep improving? Or what is a kind of information that they would feel motivated by receiving and would benefit from? And coaching feedback, again, is different from appreciation, where we want to identify accomplishments, impact, and achievement, and recognize that that can also motivate people to keep going and is often very important for people to recognize the impact of their work and that their work matters. So to get from evaluation or what the kind of standard approach is to these other types that may have more value for healthcare professionals, we developed some ideas around motivating information. And this is what we're looking for in the performance data to recognize that the information people value is based on comparisons, trends, the combination of those into the achievement of a goal or dropping below a threshold. But also there's other kinds of information that people value, getting close to goals, seeing that the changes they're implementing are working, and then sustaining performance at a high level in streaks. For each of these, there's different characteristics that we might use to prioritize, what could matter most across anyone's set of performance data. So kind of looking at the size or magnitude of these characteristics and recognizing these are different. If something never happened before, it's the first time, that might be very significant, but you may have achieved something, a few months ago, and so reaching a goal isn't necessarily that significant. So we've kind of modeled this domain as a series of performance states where we can see that there tends to be these categories of performance that are associated with each type of feedback. And I think the typical approach would be to kind of turn those red or green based on a comparator. And we're aiming to go beyond that, and we can go beyond that by recognizing that the type of comparators we use interact with trends in performance to potentially work on different psychological mechanisms. And so comparisons with goals and standards enable one set of messages where someone is seeing if they've reached a goal perhaps they've set, perhaps their organization has set, or their team has set. And the mechanisms of these kinds of comparisons are very different from social comparisons, where people are being compared to their peers or other hospitals, perhaps other teams. And then there's another set of comparisons that we might want to notify people about important high-value information, but without kind of being specific about what the comparison is, rather letting them examine the data or explore what they want to explore without kind of putting something in their face. Or to just focus on improvement when low performance doesn't necessarily matter, but improvement is significant. So to capture all of these states and mechanisms, we created a knowledge base called the Precision Feedback Knowledge Base. This has a set of common theoretical mechanisms of feedback, a set of kind of default messages and visualizations, and then a model for representing preferences and prioritization. So all of these are a work in progress. We're continuing to develop these publicly in a GitHub repository, And we were hoping this can be a resource for feedback systems research and learning about how to improve the use of feedback. We developed Scaffold then as a precision feedback system that operates on the precision feedback knowledge base. It's licensed under an Apache 2.0 license and is available on GitHub. And its architecture is a software pipeline where we begin with a standardized model of performance data, a kind of standard ingestion model based on FHIR that contains identifiers for recipients, the comparators, the performance levels attributed to those, as well as the performance measures and time intervals, and then optionally data about preferences. Once those data are loaded, we analyze that to look for motivating information, and we can think of that as signal detection and find the comparisons and trends that are there. And then we match those up with message templates that express that, appropriately for each type of motivating information. Those are expressed with a standard message, and we call those candidates that are then evaluated with a prioritization algorithm or a selection algorithm. And then we choose, we can choose the best message or the top messages to put into a report or perhaps to generate in the future as a standalone report. When that message is generated, we also have a rich set of metadata, including data about what theoretical mechanisms do we think this message uses, what is the content and how is this delivered, et cetera, so that we can enable a learning systems approach where we hope to be able to more rapidly iterate and adapt feedback based on the effectiveness and based on engagement. Now that we have this in-depth kind of these specifications about what works and how those messages were delivered. So we've applied Scaffold in anesthesia care, working with the Multi-Center Perioperative Outcomes Group, or MPOG, which is a national consortium for healthcare quality improvement and research. And MPOG has a national committee that develops a large set of quality measures. A little bit more background about MPOG is that they were developed initially to focus on observational multi-center trials and have since expanded into quality improvement infrastructure and education for anesthesia residents. And they are supported by Blue Cross Blue Shield of Michigan just for hospitals within Michigan. But there's quite a large, diverse set of data flowing into MPOG each month from a range of sources. Much of this began with high quality telemetry, data from anesthesia machines that it's trusted and very close to the care process. So these are reported monthly, and MPOG has done a lot of work to set up IRB approval, data use agreements, and to support national research scale. So it's grown across the country, starting in Michigan, and has continued to grow to 2 countries internationally. As of 2025, there were 25 states with institutions participating in MPOG. And so this has involved a large number of healthcare professionals. This is the number of anesthesia providers participating in the network, which reached, I believe, 13,000 in 2025. So a big part of our collaboration with MPOG was working with their set of performance measures that are routinely developed and reviewed by a committee of anesthesia providers with national representation and kind of a consensus process. There's more than 70 measures, and we worked with the process measures of clinical practice, but there's a larger set that also addresses a wide range of clinical outcomes and and even sustainability measures, for example, reducing climate-sensitive gases that are administered during an operative case. MPOG also has a provider feedback email program where participating institutions who submit their operative case data then are assessed for all the criteria, and any case that's appropriate for any measure is then included in this email, where providers are shown their performance on that measure for cases from the previous month, with comparisons to their peers and to a kind of MPOG-wide goal or standard. And then institutions choose what goes into this email. So not everyone gets all the measures. It's a subset that the institution chooses to focus on. So to apply scaffold, we then did an enhancement where we looked through that data, and the only difference across the intervention arm and the control arm of our trial was that this message was added at the top, kind of highlighting what we thought was the highest value message that we could find, often with a visualization beside it. So then the objective of our trial was to understand, does this kind of enhancement lead to improved performance through changing providers' awareness about opportunities to improve? And secondarily, do providers engage more with these emails? So we developed a measure of care quality across all measures where there was room for improvement. And then we set up two engagement measures, click-through rate and dashboard login rate, to test. We had a 6-month baseline period and then a 6-month intervention period. So providers in the intervention arm could receive up to 6 enhanced emails with these kinds of messages. And they had links to the measure specification on the MPOG website, as well as a quality dashboard where they can review more details about a specific operative case to see kind of how things went. We developed a set of 14 measures. 10 of those were coaching messages. 4 of those were appreciation messages. And those were set up in our knowledge base for the trial. And then we created a model of motivational potential to prioritize these messages. And we biased it to avoid repetitive messaging. So we wanted to keep showing different measures and different messages to change awareness as much as possible. And it also reflected our preferences as a study team, where we decided to always prioritize coaching messages over any appreciation messages in this case for this study. And then it additionally incorporated recipient preferences for those recipients who took a preference elicitation survey. So we ended up, at the time, we worked with 12,000 providers were in the population, with more than 60 institutions. This included certified registered nurse anesthetists, as well as attending and resident anesthesiologists. And the institutions in MPOG are health systems effectively. So if it has a single email domain, that's an institution. And that included both community hospitals and academic hospitals. We received ethics approval for a single site study at the University of Michigan. We used obfuscated identifiers so we could track provider engagement over time without their identifying information. And then we did not include any protected health information in this study. And we were approved to administer an opt-out enrollment process for the trial. And that meant that we did 2 stages of opt-out. We invited institutions to opt out, and then for those institutions remaining, we invited providers to opt out. And because this was a pragmatic trial, we had a large set of exclusion criteria that we specified to remove providers after the study to prevent contamination and recognize lots of situations where providers, change from a resident to an attending, or take a vacation, et cetera. So these are the larger set of exclusion criteria. I'll let you read those later. if you'd like to. Essentially, we're going for apples to apples comparison and to try not to bias the arms of the study. We developed a primary outcome, which was we call it a measure success rate. We can think of it as an overall adherence to all measures. So this was for the 6-month window where these messages were being sent in the intervention arm. And we have a simple ratio here where providers' data looked like this. As a provider did multiple operative cases, those cases were included for different measures. Some would be appropriate for a measure, others not. So where cases were appropriate, they were determined to either pass the metric or be flagged as not passing. And so then from there, we got a simple percentage that could be attributed to each provider for the 6-month period. To analyze that, we fit a 2-level model to this measure success rate, recognizing key differences that could be related at the institutional level, such as the average case complexity, and at the provider level, such as provider workload. And this last one here is something else we developed to recognize that some metrics may be harder to improve. They may be more within the control of a provider or less within the control of a provider. So we looked at the average annual improvement to account for the fact that some measures might be more difficult to improve than others. The 2 engagement measures we used were a click-through rate and a dashboard login rate. And for clicks, we basically said any email that is clicked on with 1 or more clicks counts as an engaged email. And similarly with dashboard logins, any month where someone logged into the dashboard following the delivery of a message counted. So we haven't published these results yet. We're finishing our analyses. These have not been peer reviewed, so please take these findings with a grain of salt. These are preliminary findings, and we were able to recruit 46 institutions to participate. A very few providers opted out. So we started with 11,445 providers enrolled in the trial. During the trial, we generated messages, and for those providers in the intervention arm, they received about 4 messages out of the 6 months on average, with 82% receiving at least 1 message and 64% receiving at least 4 messages. I mentioned, we prioritized coaching messages. So the top 10 messages here are coaching messages. You can see we selected and delivered a lot more coaching messages than appreciation messages. And the top coaching message was "you are not a top performer," whereas the top appreciation messages was "you are a top performer." But we can see there's some other very frequently delivered coaching messages, like "you may have an opportunity to improve" with a social comparator. After the trial, to account for the change in provider roles, in movement between arms or across institutions, we excluded a lot of providers. This resulted in 1 institution being excluded, and we were left then with 6,645 providers, with the control and intervention arms fairly balanced. For our primary outcome, we found high skew in the data. We used a robust linear mix model to downweight outlying observations, and we did not see a significant difference in the measure success rate between the arms of the study. We also did a sensitivity analysis to look at those providers with more room to improve, and we also have not seen a difference in the measure success rate. We can see, looking at this box plot, the control arm is on the left. There's a lot of variation in performance at the institutional level. And so we do see a lot of spread, but an overall kind of high performance where, mostly we're looking at performance being above 75% for most of these measures. We found that for our covariates, as expected, where baseline performance was higher, there was less improvement. There was also less improvement at larger sites, larger institutions, and where providers had higher case volume as individuals. And finally, academic medical centers improved less, presumably due to case complexity and perhaps size. For our secondary outcomes, we saw a lot of automated clicks and excluded click data that was a result of just email clients clicking on all links to do security checking. And we noticed overall the click-through rate was 11%. And we used logistic regression to compare the difference between the arms and found that click-through rate was significantly higher in the intervention arm. And then we did not see a difference in the dashboard login rate across the arms of the study. So that was a brief run through of our trial. And I think the takeaways are, we demonstrated that we can do this kind of precision feedback approach at large scale for healthcare professionals. We also saw significantly more engagement in the intervention arm. So we think there may be a basis for understanding more about what is useful, what is beneficial to clinicians by changing their awareness of their performance. And we've done this with an open source system with open resources that we hope will be useful to researchers and may advance the way we study and optimize feedback going forward. So we also have theory-based intervention data that we're looking to analyze further, and we're hoping that we will find interest in those who are interested in using behavior change theories and kind of representing explicit knowledge about how these interventions work in combination with machine learning and other automated approaches. So we did choose a population where performance was relatively high, and that created ceiling effects in spite of the large scale and the large population. We didn't assess the significance of performance for each metric. We treated metrics largely as equivalent across all types, even though their metrics are very different, with the exception of this measure difficulty covariate. We think another limitation is that this is part of a routine feedback system where for most providers, they've already been getting these emails, and if engagement is low to begin with, which we believe it was, providers may not have seen these emails because they had already sort of gone through a period of not finding value in these emails. And then finally, we didn't partner with patients in this research. And I think that probably resulted in us missing opportunities to really get at issues that matter to patients and providers. And so that's something we're looking to change in our future studies. In terms of next steps, we're continuing to analyze the data, and we are adopting a machine learning approach and looking to incorporate more machine learning models to benefit the knowledge base and anyone who wants to use this approach. And we believe this is relevant to a wide range of feedback processes in health systems. So we're looking to apply this and working on some early implementation of and development of scaffold for other contexts, and including looking at how team leaders can use feedback, how we may be able to make inferences for multi-level feedback interventions, and to support adaptive coaching where providers want to sign up for coaching and then also like MPOG as a kind of learning network to recognize where this has value in collaborative learning communities as a kind of infrastructure that can benefit collaborative learning systems. So I would love to answer questions. Thank you again for allowing me to share our work and look forward to discussing this if there are questions or comments you'd like to share.
All right. Thank you all. We have about 19 minutes remaining for the Q&A. If you have any questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A. While we wait for some questions to come in, what would you say is the most important single takeaway for our audience?
I think the primary takeaway is that we've demonstrated that we can do this as the first kind of implementation of scaffold at large scale. And it's exciting that we saw engagement and significantly more engagement for providers who receive these messages. So I really am excited about the potential we have and the potential broad relevance of this. The theories, we've based this on are not specific to anesthesia care or even healthcare. So we're very interested to explore, how this might be applied in different modalities and in different contexts.
Can I jump in and ask a question, Andy? Is that okay? I don't want to cut the line at all.
No, go for it.
Um, Zach, do you mind telling us about the kind of experience of working across all these different institutions? A lot of the learning health sciences work that we try to do where we're kind of broadening beyond one individual institution is often the goal, but can be really tricky as you're juggling different institutional priorities and contexts and ways of working. Can you just kind of tell us a little bit about how you managed that for this project or for others? Because I know that you work across institutions in your other work as well.
Yeah. Definitely. I think something that I've learned that makes a huge difference is kind of the maturity of infrastructure in a network and the degree to which the things that are measured are organized on one kind of foundational unit of analysis. So for MPOG, I haven't seen this I've only worked with a handful of networks, but I haven't seen quite the uniformity in other networks that MPOG has, where everything is counted as an operative case. So across all their measures, all their initiatives, it's all about assessing an operative case. And that's allowed them to extend, one year of data can be submitted to the registry before the case and after the case. But everything can be lined up for that purpose. Other networks I've engaged with, it's like each initiative has its own little mini registry, and then you can't do apples to apples, and you don't get the kind of synergy from that data. So I think that's something that makes it easy, and that's just how the data are developed. But in MPOG, they've really taken a kind of consensus, kind of standardized approach where everything is kind of uniform enough so that it takes away a lot of it makes it easy to collaborate. For example, all the data are housed and analyzed here at the University of Michigan. So we got a single site IRB approval. I did have to present to a research committee to have the network approve our study. And that, honestly, that felt like having my hand be held, like it's all of these anesthesia national experts kind of working together to say, like, how can we help you, make this be, the best research project it can be. And so I think, that culture and that they figured out how to make things uniform so that it's easy to collaborate. And it shows if you look at their website, you can see there's a lot of activity, and I think that's why it's been able to grow so well. As outside within Michigan, there's Blue Cross Blue Shield of Michigan supports hospitals to participate, but outside it's primarily academic medical centers who pay to join the network because they see value in participating both for their faculty, for research, for quality improvement. So that's kind of a long answer to your question.
All right. Next, it looks like we have a question from Dylan. They said, great presentation. Was workload capacity related to performance for benchmarking? How was benchmarking established in the metrics? I would imagine that there are a variety of different workloads and timings for physicians to complete tasks.
Yeah. In this network, benchmarking was done where let's see. So there's a kind of standard approach where the every provider is compared to the average, and I believe in the standard email, um, you see your peer average, which is just for your institution. So other providers at your institution, you get compared to that average, and then people use the word benchmarking to mean different things. So if you ask me about benchmarking, I'm thinking social comparison and comparison to peers. Uh, we have lots of words for comparators: goals, targets, thresholds. If you mean goals, or the kind of like just something that's arbitrarily set by an individual or an organization, MPOG also has for each measure a network-wide goal where kind of they've agreed that it's appropriate for you. No one's perfect. Things are always very complex. So, it's appropriate for you to be at 80%, and you might want to try to stay at that level or above. And whereas for benchmarks that are social comparators, that was implemented as a peer average. So what we did though for the precision feedback was we set up multiple benchmarks where we chose a 90th percentile among your peers in your institution, and then we had the peer average so that we could kind of notify people when they fell below average or were operating below average, and then when they were above being a top performer. And so we used both of those benchmarks. But in terms of, that was that's also specific to each measure. And so there's multiple, we would assess performance at that institution or obtain those benchmarks for that institution, and then see what messages we could generate for each one, from our candidate messages. So I think, the other thing I detect in your question is, what does this work like? And of course, for operative cases, there's so many different specialties and contexts, where people are having surgeries and procedures. And then, for any case, there's different practices, and some of those are, largely within the control of the provider. For example, reducing anesthetic gases that are climate sensitive. That's an initiative that, doesn't necessarily involve team decision making. Whereas there's other things like, prescribing appropriate anti-nausea medication to the patient. It's the provider's decision to do that, but it's something that it depends heavily on the patient and the context. So I think we also have, certified registered nurse anesthetists and resident anesthesiologists. MPOG is onboarding training for certified registered nurse anesthetists. So there's quite, there's a variety of tasks and professional roles, and then comparisons across all those groups.
It looks like we have a follow-up comment from Dylan. Interesting benchmarking as social comparators and with a peer average, multiple benchmarks specific to each measure. Thank you.
Mhm.
I have another question, if you don't mind, Zach. I've been thinking a lot about clinician kind of um, burden and burnout and how we're managing that in the healthcare system. And I'm curious, maybe in the literature or maybe in your own kind of interactions with clinicians, how folks think about this kind of coaching and appreciation balance in the context of folks feeling generally pretty like stretched and burnt out. Are you hearing anything from the folks that you're working with, or is there anything in the literature about kind of in the context of burden and burnout, how we think about the balance between coaching and appreciation, or just how you think about it personally?
Mhm. Mhm. I mean, yeah, that is an important thing to understand in our context, and it's complicated because people are different, the context matters, and things keep changing. And yet, we know that people operate in certain ways. So I like one lens is stress. And there's good kinds of stress and there's bad kinds of stress. And when we did some design work to develop these messages, and we would hear one person would say, okay, I'm reading this message, it says you're not a top performer. And they would say, thank you. Like, this is perfect. Like, a lot of the information I get is not very high value. That's exactly what I need to know. Like, there's something I can work on here. Um, and there were people who were like, this is awesome. And then other people would read the same message and say, I don't, if this was in my inbox, I think I wouldn't ever open that email again, or open any subsequent emails. So I think a lot of it depends on what is your orientation to your work and this kind of performance improvement. And there's good kinds of stress, there's bad kinds of stress. Um, and then I want to also recognize that we're showing what's possible with this performance data. And um, it's not that we're locked into email or that email is the way of the future. And I'm hoping we can get away from that, and really that this demonstrates, what we can do. But really, it's about teams communicating, and whoever, perhaps a quality improvement leader communicating about what matters to their team and generating messages that a team leader could select. And it's unlikely that we're going to have a single source of email, just coaching everyone from a centralized point. And I think the real value of this is in interpersonal communication, team communication, where we can show a team leader or anyone who has performance data they want to communicate about, how to do that in a way that's of value. Um, and then kind of the other aspect of your question is about balance. And there's a lot of ideas about, what is effective feedback. And maybe there is a common thing called 5-to-1 feedback, where it comes from studies, I believe, of couples, where they notice in, communication between couples was more positive and effective, where there was kind of 5 appreciative or positive things said for every one uh, ask or kind of negative thing. And so that's something we could test out with Scaffold. We could set up an algorithm where it's going to appreciate 5 things every in a row, and then every once in a while you'll get a coaching message. That's a different way of working. I think there's a lot of algorithms we could try. Um, and then giving people control over what's best for their context is ultimately going to be, I think, the way forward, because there's so little we know about what's going on in any context, and sort of equipping team leaders, especially with a steering wheel for this. I think that's a direction I want to investigate. I think where we could there would be a lot of potential there. Um, so. I think I have noticed there are some people who really value appreciation, and I think that is underutilized. For me, that's a motivator that's not really used enough. And there's psychological theories that, point to appreciation as this huge motivator to, let people know your work matters, what, how the impact you're having. And often we're focused on, where are things turning red and solving the problem. That's necessary too, but I think the appreciation side is probably underexplored. So,
Great. Thank you so much.
All right, we have about 4 minutes left. Do we have any closing questions?
I'm glad to wrap up by, oh yeah, a tutorial. Thank you. I see the question is there a tutorial on using Scaffold? We've made some early resources on our GitHub website. There's READMEs, there's a wiki, and there are some vignettes to kind of illustrate how Scaffold works. We're working on making it easier to implement Scaffold and quickly understand how to get it running. So I would encourage you to check out our website. I shared a link. It's in the slides as well. And our GitHub repository. And we're working on a setup guide and other resources for configuring the knowledge base. So I do want to recognize that I do think this has potential to be an important part of learning health system technical infrastructure, where the goal is to make learning easier and to make feedback interventions more adaptive to, enable large-scale networks to optimize feedback, to recognize when these are of value, and not just, sending out, here's your data every month to review. So I think I could probably end there with the takeaway.
Well, thank you so much, Dr. Landis-Lewis, for taking the time to give this talk, and thank you all for attending. Again, in closing, we will not have a seminar next month, but please join us at our next seminar on August 4th at noon Central Time. This concludes our presentation. We'll see you next time.
Thank you.